Hello, I'm Tony DeMaria, the editor of JACC, and I'm here with another edition of the Genuine Article. And this is a show where I talk to you about one of the really interesting manuscripts that we've either just recently published or have in press. And on this occasion, what I'd really like to talk about is one of my favorite topics, and that is, how do you handle a manuscript that is imperfect but provides some data, some guidance on an important clinical issue which is otherwise undefined? And there are a number of such clinical issues, decisions that we have to make on a daily basis for which there are no randomized controlled trials, and for which evidence-based medicine really is not very feasible because the evidence base is not available. And there are numerous examples of this, but the one I'd like to talk to you about now is, what does a physician do when they are confronted with a patient with congestive heart failure, acute decompensated congestive heart failure, and they're on beta blockers? Obviously, many physicians would look at such a patient and say, well, they've decompensated. I better withdraw the beta blocker until I get them recompensated and then perhaps restart it again. But is that the best course of action, or should we continue the beta blocker? And again, this is a common question. It's an important question, and it's one for which no randomized prospective clinical trial data exists. And so in that void, we have to use the best data available. And we do have, and in fact, JACC has published some data from retrospective looks at small patient populations included in randomized clinical trials for other purposes. But in a forthcoming issue of JACC, we have data from the optimized registry. And I'll remind you, the optimized registry was a so-called real-world registry. That is to say, there were a large number of hospitals that were cataloging the management and course of patients admitted for acute decompensated heart failure. And from the optimized registry, Dr. Greg Fonarow and colleagues examined a group of over 2,000 patients who were admitted and who were prospectively followed for 60 to 90 days to determine their outcome based upon whether they had beta blockers continued, whether they had beta blockers discontinued, or whether they were never placed on beta blockers in the first place. And of this group, the vast majority of them either had beta blockers continued or discontinued. And in fact, the vast majority of these patients had the beta blockers continued. There were only about 12.5, under 13% of patients who came into the hospital on beta blockers in whom they were discontinued. And when these optimized investigators looked at the ultimate data, what they found was that overall mortality, or the risk for overall mortality, was actually substantially less in the patients in whom beta blockers were continued. In fact, they had a risk of mortality of 0.6, fairly impressive. And in fact, if you looked at mortality and rehospitalization, it was still a reduced risk of 0.69. In terms of patients who had beta blockers discontinued, their overall risk was 2.3, so over twice as great. And so ultimately, looking at these data, the conclusion that was drawn was that, in fact, patients who were continued on their beta blockers during their course of hospitalization actually benefited and had a lower risk of death and or rehospitalization over the 2 to 3 month period. Now, the first question that jumps to mind immediately is, well, of course that's true. Patients in whom the beta blockers were stopped were probably sicker. That's why the beta blockers were discontinued. And so it's no surprise that sicker patients will do less well than healthy patients. However, what these investigators did was try to carefully match the risk of the patients, and they did propensity scoring, propensity analysis. Now, we know propensity analysis is imperfect, but it's a recognized attempt to correct for variables that may account for why a physician takes one course of action rather than another. And the data that I've just cited for you come after the propensity score. So in fact, as much as is humanly possible, an attempt was made to eliminate the variable of severity of disease as the reason that the patients who were discontinued from beta blockers did less well than those patients who were continued. Now, there's a reason to expect that this might happen. Not only are beta blockers effective therapy for heart failure, but we've known for some time that there can be a rebound phenomena if beta blockers are discontinued abruptly, and that may well have played a role. And there are, of course, a number of limitations to this study. It was a registry study. It was using an administrative database, so in fact you depend on whether variables were actually documented or not. And unfortunately, we have no reason for why the beta blockers were discontinued in the patients in whom they were, and so we can't account for that variable. So imperfect data, very imperfect data, but at least some evidence for an important clinical question. What I take away from this paper clearly is that in my patients with acute decompensated heart failure who are on beta blockers, I'm going to make every effort to keep them on beta blockers. I don't think we're exposing them to undue harm, and the likelihood is that if we can continue the beta blockers, they'll benefit. I'm Tony DeMaria. Thanks very much for watching the Genuine article.
Have a question or comment about a CVN story? Send us an email at cvnfeedback@acc.org.